Well, hello there. I'm your host for today, Dr. Kate Kresge, and we have a really important episode for you. I'm talking with Dr. James Greenblatt, the founder of Psychiatry Redefined.org, about suicide prevention. Now, it's Suicide Prevention Awareness Month, and this episode is incredibly important if you or a loved one or any of your patients struggle with suicidality. We're going to talk about a biological model of suicide prevention, meaning, how do we understand what's going on in the brain of people who are struggling with suicidal depression? How do we assess their blood and their biochemistry for biomarkers that we can then use to inform effective treatments? Now, there are decades of research that support screening for things like cholesterol levels, vitamin D, omega-3 fatty acids, and other biomarkers in helping to create a holistic plan to help someone prevent suicidal ideation and attempts. This is a really powerful episode for anybody who's looking to become armed with the information that they need to have to effectively treat patients with suicidal depression or advocate for their loved ones who are struggling with it. Understanding how you need to assess for levels of inflammation and the root causes, nutrient deficiencies, and low levels of really important fats for the brain are going to level up your ability to help someone who's in a space where they're struggling with this. Now, if you're a longtime listener of this podcast, you'll have heard Dr. Greenblatt come on to talk about ADHD and eating disorders. He's a functional psychiatrist with over 30 years of experience. He's the founder of Psychiatry Redefined, which is a fellowship and training program for medical professionals who want to learn how to treat mental health disorders using a holistic, evidence-based approach. He was also the director at Walden Behavioral, an inpatient-outpatient treatment center for over 20 years. He's an assistant clinical professor at Tufts University School of Medicine, and his course materials are included in residency programs nationwide. Last word here before we dive in. This conversation could be intense, and so don't listen to it before you have to go do something where you really need to be completely regulated and fully present. I recommend that you set aside some time to listen when you're feeling ready to hear this information, synthesize it, and take some action. Now, let's start the show. Dr. James Greenblatt, welcome to the Root Cause Medicine Podcast.
It's great to be with you again, Kate. It's always a pleasure.
Today, we're talking about suicidality and severe depression. And I'm really, really thrilled to have you here because you just made one of your most important courses, in my opinion, free for people. So can you talk to us about the course you have, why you made it free, and why it's so important to release this now?
Sure. I think let's just take the big picture first. Suicide rates just continue to spiral globally. So rates are increasing. At the same time, our traditional model, we have more medications, we have more assessments, we have more hotlines, we have more screening tools, we have more of every resource that has been put in to just support this model that's clearly not working. So, as you know, as a functional psychiatrist, the information and the research is just so striking about looking at biomarkers that can predict suicide risk. And that's the information we just want to get out there. And certainly Suicide Awareness Month is just a powerful time to rethink the current model.
I love that. And if you're a parent or a lay person who's not a doctor who's listening, I want to frame this a bit before Dr. Greenblatt and I dive in. So any functional medicine provider who's listening, who's dealt with mental health clients, knows that when you run certain tests, cholesterol, omegas, lithium, vitamin D, inflammation, all the things Dr. Greenblatt and I are going to talk about today, that you often see abnormalities in the blood and even, based on research, in the brains of people with severe depression and suicidality. But that research is not making it into the clinic. And so what Dr. Greenblatt and I often hear is stories of people who take their kid to the doctor and almost no labs are run. And these parents and these people are wondering, isn't there something in the body that could be going on that we could do some root cause detective work around? And so, Dr. Greenblatt, in my opinion, you are the most informed person on the planet on this topic. You've been compiling the research on biomarkers in suicide and depression for over 30 years. What have you found? And if you just had 2 minutes to tell people, these are the biomarkers that are the most important to look at, where would you start?
Yeah, I probably need 20 hours, not 2 minutes. But I think also to put in perspective that I've kind of had this double life. I was in a traditional inpatient psychiatric program for 30 years, which means I saw patients who attempted suicide, actively suicidal, for 30 years of my career. And I've also been in this functional psychiatry world for 30 years. So it just was painfully obvious to me that our current model is not working. So putting those two spheres together and then delving into the research, you're able to kind of make very common sense conclusions about low levels of fat in the brain, low levels of certain micronutrients, inflammation. Now that we can use that word since COVID and seen what happens in the brain with inflammation and infections. And clearly, we're not dismissing any of the psychological stress and trauma that often drives it. Or we'll need an hour to talk about the social media that kind of fuels this flame. But the brain is a biologically based organ. Our inability to inhibit that impulse to die is biological. And that's all I'm trying to articulate. Can we optimize the biology? It's not going to eliminate depression and stress, but it is going to be the foundation for treatment. And I'm convinced the foundation for a model for preventing suicide.
I love that. So one of the ways I hear people who specialize in functional medicine in the brain think of suicide is that somebody's brain is sick. And so there's a couple places that we look to determine what's making their brain sick when they come in with suicidal depression. Can you start us out with the category that I hear you talk about a lot, which is the fats? Why do you look at cholesterol? Why do you look at omegas? Why are those important for brain health? And what do we find when we look at those levels in people with suicidal depression?
Sure. And the theme through all my work, and we'll keep coming back to, is everyone's different. And that's why testing is so important. But the dry weight of the brain is 60% fat, right? Nothing happens well if we don't have adequate omega-3s, the polyunsaturated fats, and that our demonized cholesterol molecule over the past 50 years, I believe, has wreaked havoc on mental health. And what the literature has clearly established, there are some individuals, likely genetic vulnerability, that have what I term very low cholesterol. Total cholesterol numbers under 120. We've seen total cholesterols of 60s and 70 and 80. And the research has established, and I've seen it often, these individuals are at high risk for severe depression and increased suicidality. And in our medical culture, lower cholesterol is better. Now, if you lower cholesterol with statins, we know there's a black box warning for cognitive decline, and we see depression. We don't often see that same intense suicidality that we see with these very low cholesterols. So in this model that we're trying to present and talk about is, why wouldn't we test a lipid panel for that adolescent or that adult in the emergency room that's made 3 suicide attempts? And if they did have a cholesterol of 100, then the research is saying high risk for suicide. Why wouldn't we address that?
I think a lot of providers are probably taking notes already, thinking, oh, okay, all right, I need to run a lipid panel on someone who you just described. But then they're wondering, as a doctor, they know how to give someone statins if their cholesterol is too high. Can we talk for a second about what might cause cholesterol to be too low and what some of the things we can do to actually help someone get it to a normal level? I'm hearing you say above 120 if they do find a cholesterol in the 60s or 70s.
Yeah, some of the research demonstrated under 140 increased rates of depression and suicide. But I found the 120 is a place to kind of make a huge dent. And we'll come back to the other fats, the omega-3s, but with the cholesterol story, it is challenging to raise levels, but that awareness of an increased risk is just a profound step to prevention, right? When we identify the increased risk, that's what all of our models of prevention here. So we have that increased risk, we provide more support. Increase in cholesterol is challenging. It takes time. We use digestive enzymes, and there are also times we would use cholesterol supplements. There are supplements of 250 milligrams of cholesterol that for some individuals we've used with a pretty great success around mood, but it takes time. It takes time to raise cholesterol levels.
Yeah, and I'll jump in here just as someone who also saw this in practice. And guys, I did see this in people who had been taking statins whose doc said, come back in 6 months, come back in a year, come back in 3 months. Let's check your cholesterol levels because we're putting you on this new cholesterol lowering medication. The person got busy. They never went back to the office. They've just been taking the statins for years. And now their cholesterol is way too low. It was part of their picture when they would come in the clinic. And so what Dr. Greenblatt alluded to with the enzymes, I mean, what we're taught as docs is part of the root cause of low cholesterol can be a medication you're taking. But another root cause can be inappropriate absorption of your food. And so things like celiac disease, pancreatic elastase issues can be in the way. And so a good doc is going to do that workup to figure out, all right, if it's not a medication, what else could it be? And then, like Dr. Greenblatt said, do things to intervene. But I think even for someone who's in the depths of what feels like despair, hearing there's something up in your blood, we can try to fix it. This could be contributing to your mood. Give us a few weeks. Can be really impactful when you're feeling so poorly. And so just having this information can be life-saving. But then what Dr. Greenblatt is also saying is it also raises your suspicion of the level of risk, right? And how closely you may need to watch this person, how much support you may need to bring them while they're in this place where their brain doesn't really have enough cholesterol to work. So doc, you're saying like the brain is mostly made of fat. You talked about fat and we're going to go back to omega-3s, but what is cholesterol actually doing in the brain that's so important? And why would it impact mood if it's low?
I think we just got to visit for a minute what cholesterol does in the body. As one of our first teaching points in psychiatry, Redefined, is we have a neck, right? What happens in the body affects the brain. So just think about it for a minute. Cholesterol is the precursor to every steroid hormone in the human body. So our testosterone, our estrogen, there are hundreds. So the precursor, also to vitamin D, also stabilizing membranes. Cholesterol is critical for bile salts, so we digest fats. And specifically in the brain, it stabilizes the receptors, so the brain doesn't work well. I mean, we've demonized this molecule so long, we forget how essential it is for human physiology.
Mm-hmm. Beautiful explanation there. And guys, we know if people's testosterone is really low, if their steroid hormones themselves are just low, people can have severe mood impacts. I mean, estrogen sensitizes your receptors in your brain to neurotransmitters. So you not only have cholesterol, but you might have issues with your steroid hormones, and then they're just combining to make it a really difficult environment for your brain to respond correctly, even if you're making all the right amounts of neurotransmitters, which tends to be what all of us focus on when someone's not feeling well, right? It's like the neurotransmitters, the neurotransmitters. We have to think about the environment that they're in. And so cholesterol is a big part of that. Let's talk about omega-3s. Why are omega-3s and omegas the other type of fat you focus on, Dr. Greenblatt?
Well, there it's been a little easier for both the research and clinicians to appreciate. We probably have 30 plus years of research looking at omega-3 deficiencies across many mental health challenges, but specifically, we have research from our military, our government, and many labs around the world, low levels of omega-3 associated with higher rates of depression, higher rates of attempted suicide, and higher rates of completed suicide. We have studies looking at what people eat, and we have studies looking at blood tests, levels of DHA associated with increased suicide risk. And it's just astounding how much work there is and pretty much ignored by our clinical community, as you discussed in your opening.
Omega-3s, I know, inhibit the conversion of arachidonic acid to a certain extent to pro-inflammatory mediators, meaning they are anti-inflammatory to a certain extent. And I also know that they're antioxidants, so they help to protect our cell membranes. Beyond those two things, do we have other ideas about why optimal omega levels are so important for helping to stabilize mood?
I think whenever we jump into any of these micronutrients, particularly an essential, like when we talk about lithium or these essential fatty acids, I think the list is probably 100 pages as to the role in human physiology. So certainly, as you described, it's anti-inflammatory, antioxidant, but it's a basic building block of our cell membrane. And that's how everything happens in the brain and the human body, and just multiple layers of research supporting the association with depression and suicide risk.
And just so you guys know, the cell membrane is where these receptors for hormones, for neurotransmitters, are located. And you want that to be really fluid and flexible so that it can send and receive the right signals. If that's not happening, it's going to create a lot of stress in your body and a lot of dysfunction, just to put it simply. So if you're listening to this and you're thinking, all right, I know about cholesterol, I'm already like a little lost in the weeds with omegas. Does this just mean I have to take omega-3 fatty acids and then I'm good? You have to work with a professional to determine how much. I just want to dive for a second, Dr. Greenblatt, into food sources and dosing for omega-3s. I personally have found that most of my clients do not get a benefit from omega supplementation unless we are hitting a total of usually 3 to 4 grams at least between dietary intake, and supplementation. If I'm just giving them a half a gram a day, it does not seem to make a difference. And the literature actually supports this from what I've read. But if you're listening at home, guys, if you're not eating salmon, flax seeds, chia seeds, walnuts every day, you are probably not getting enough omega-3s unless you're supplementing, because those are the top food sources in the US diet of omega-3 fatty acids. And plant-based sources have a poor conversion rate to actual omega-3 inside of our bodies. So you have to eat a lot more of them to get the basic amount of omega-3. So Dr. Greenblatt, when you're using omega-3s with someone, I know this is completely personalized to the individual. Everybody needs to talk with their own doctor before they would ever start omega-3, particularly if they have any bleeding issues, right? Because omega-3s can interact with certain medications and conditions. But in general, do you also feel like there's a certain threshold before omegas start to work where it's not just 250 milligrams or 500 milligrams? Can you talk to us about that?
Sure. No, I agree with you 100%. I have that same magic range, at least 3 plus grams total a day in supplementation.
Love it. Yeah. It's interesting, guys, because even the doctors I talk to will say, I'm taking my omegas. Yeah. And I go, well, how many grams? Like, half a gram a day. It's like, okay, if you're inflamed or depressed, that's probably not enough. And wouldn't you know it, usually when they increase, they see a major difference. So that's one lever to push with your doc or your kid's doc. If your person is taking omegas, but they're only taking a little bit, or you guys just kind of went out and pulled one off the shelf, it's worth a conversation about the right dose to make sure that you're on the right track. Now, you mentioned lithium and vitamin D earlier in the talk, Dr. Greenblatt, and so I want to circle back to those. Those are two of the most commonly mentioned nutrients I hear you talk about in these conversations. Why do those make it to your top list?
Well, I mean, the vitamin D issue is just simple, and the implications are clearly profound. And vitamin D has effects on every cell in the human body, but it's the rate limiting step for the synthesis of serotonin, critical neurotransmitter. And as I've said 100 times so far, the research is very clear that low levels are associated with depression. We have studies on dementia and Alzheimer's, and suicide risk. We have studies of hundreds of thousands of people looking at low levels associated with increased risk. Now, again, doesn't mean everybody who is thinking of suicide has low levels, but to have an objective biomarker that we can test and then treat. The repletion is simple. We're talking about 30 or 60 days of repleting to optimal levels. And it's not going to be the miracle cure, but it's going to be the foundation to do all the other work, whether it's other micronutrients or the therapy that's involved. So vitamin D is so important because it's so simple. You do a blood test, you treat, and you do a follow-up blood test. It's that simple. Not everyone who's suicidal has low levels, but we've seen dramatic levels under 10. We've seen undetectable vitamin D in a blood test for those individuals with severe depression and suicidality.
Super impactful, easy to test. And guys, if you have a loved one who's in treatment for any of this, whether it's inpatient or they're seeing a psychiatrist outpatient, a psychiatrist is an MD. They can order labs for your loved one or for you. And so just asking them, can you check my lipids? Can you check my vitamin D? Can you check my omegas? Super simple thing that you can check fast wherever you get your labs normally drawn. That will give you just more information as you go through this journey. Now, let's talk about lithium. That is not a nutrient that most people probably think of when they think of nutrients at all, but then definitely when they think of depression. Why does that make your list?
It's critically important. I've actually been interested in lithium for 40 years before I was a practicing physician. It's been fascinating. Lithium is a mineral. It's in the Earth's crust. Lithium is a nutritional supplement. And yes, when many of us think about lithium, it's a pharmaceutical, it is a medication. So if we take each of these categories as a medication, lithium is anti-suicidal. There is no traditional psychiatrist or researcher that can argue that. It has anti-suicide property, the pharmaceutical. But we're not going to talk about that. We're going to talk about the element in our water, our tap water. We get lithium. We've also demonstrated across the globe, indisputable research, that the amount of lithium in our drinking water can predict suicide risk. We're talking about micrograms. And then clinically, without a lot of research, but clinical myself and people across this country, that using nutritional lithium as a supplement, we've been able to improve depression and decrease suicidal ideation. So lithium is an element. Lithium in your water, we eat it and drink it every day. Lithium is a supplement. And yes, lithium is a medication.
I love it that you break it down like that. And so let's actually put it in that micrograms, milligrams, grams comparison you just did. So lithium as a medication is generally lithium carbonate, which is given 600 to 1600 milligrams minimum.
Sounds good.
Love it. Then we've got lithium orotate, different type of lithium. That's a lithium supplement, which is given in maybe like between 5 and 30 milligrams. Right. So with exceptions, guys, this is why you have to work with a professional to figure out your dose. But I want you to hear the difference between 600 and 1300 and 5 and 30 milligrams. And it's a different form. So very big difference in the medication version versus a supplement version. And then you're talking about micrograms in water. So let's talk about lithium in traditional psychiatry just for a second, because someone might be listening to this thinking, I have a friend who had bipolar. They hated being on lithium, or I heard scary things about lithium. I'm not exactly sure what I heard, but I know I'm kind of scared of it. Why might that be? And what is some of the newer research that actually helps to support the different types of uses of lithium that you're talking about?
Sure. I mean, I think when we get to orotate, I want to make sure we get down to 1 milligram dosing, because tiny doses can be important. Prescription lithium is helpful for bipolar disorder and anti-suicidal, but the side effects are real. So I would only use prescription lithium for stability in someone who's bipolar, and then titrate down to the lowest dose that might keep someone's mood stable. But over time, lithium carbonate might, for some individuals, contribute to kidney disease and thyroid disease. That's just a fact. So we want to minimize our amount of lithium, and there are other things we can do to minimize those side effects. The nutritional lithium, we might go from, again, 1 to 30 milligrams. And the in-between thing that I have found particularly helpful is just very low-dose prescription lithium. So oftentimes I would use 150 milligrams of lithium carbonate, and that only has 28 milligrams of elemental lithium. So there's a lot of controversy out there of traditional psychiatrists saying orotate doesn't make sense, is dangerous. And I have integrative docs and functional docs saying, oh, carbonate is dangerous. And the message, doing this for 30 years every day, is that I don't think it's the carrier molecule that's critical. It's the amount of elemental lithium. So 150 milligrams of lithium carbonate has dramatically changed the trajectory of major mental illness for many individuals. Now, that dose is probably not enough to treat bipolar disorder, but there's antidepressive effects, help with irritability, mood lability, and for some, decreased suicidal ideation.
Brilliant. And carrier molecule, for those who are listening, if you go to get usually any mineral supplement at a store, you're going to see, let's take magnesium, for example. There's the elemental magnesium in it, but then there's another word after it, or sometimes multiple words. And the word after it is the carrier molecule. So magnesium taurate, magnesium glycinate, magnesium citrate. The second word is the carrier molecule, because elements by themselves are very unstable and reactive. So when you hear Dr. Greenblatt saying the carrier molecule, he's saying he's focused on the lithium just the element. How much lithium are we getting someone? Let's take the argument away from whether it's lithium carbonate or lithium orotate, and let's focus on the lithium. And I love that you talked about dosing, because the dose makes the medicine or the poison no matter what we're talking about with everything. And so I want to have this conversation for a second for folks who are listening. There's two different ways to do an intervention when someone's in a crisis. When someone's in a crisis, it is really useful to give them higher doses of something you know will work to stabilize them and keep them safe. And buy yourself some time to get the other supports in place to keep them healthy. And then you can slowly start to wean them off or wean them down from maybe the higher doses of things you were using in that acute situation. And that is the path of health and recovery, right? It's not, hey, we're giving you this thing, you have to stay on it for the rest of your life. It's, hey, we're trying to stabilize you right now. And then we can have a conversation about what the rest of your life is going to look like and work to fine tune and optimize. And I find that a lot of people, when they're in a crisis, can feel afraid, or they can feel like something's a big dose or something's unfamiliar and they don't want to take something, and they're not realizing there's a difference between what we're going to do in this crisis and then what we're going to do long-term to optimize your health. Do you have any thoughts about that, Dr. Greenblatt, or any ways that you would talk with families or even younger clinicians about how to frame the interventions we do when someone's in that crisis moment versus long-term?
Sure. I mean, I think the crisis around stress and depression or anxiety is different than suicidality. So let's digress for a minute. I think everything we're talking about is long-term preventative strategies to prevent those feelings, not just of hopelessness, which we all might get, but that kind of despair and hopelessness that leads to no impulse control to take one's life. That's not what we're talking about here, because in those situations, we need to make sure someone gets to a hospital, gets medicine if that's what they need. But the most important thing that we can do in a crisis around suicidality is connecting with other people, whether it's family, friends, or a treatment program. And too often, someone ends up in an emergency room attempting a suicide, and they're feeling better, and 8 hours later, they go home with no follow-up care. And we know there was a great study where they did follow up people, and the ones that got the phone call the next day and the connection with a human being did the best. So I just want to make it clear that the work that we're talking about, which can prevent those crises, it could take 3 or 4 months. But think about it. If we find an individual with low vitamin D and low cholesterol and low omegas, and we can talk about other biomarkers, and we treat those, then we can prevent the crisis.
Mm-hmm. Love that. Such an important reframe. Let's talk about inflammation, if you're okay moving on. And vitamin D is part of this conversation if you want to tie a bow on vitamin D. But so much of what I think when I see someone in a crisis like this is I feel like I can almost see the inflammation in their brain. It's clear. They're not thinking clearly. They're usually kind of bent over. And a lot of the language that I would use to talk to patients and families is about how their brain just wasn't working in that moment if they were in that crisis. We use this word inflammation, and you talk a lot about inflammation in your course. And everyone, I want to remind you, please go sign up for this free course. We cannot possibly cover all the papers, all the research, all the supporting evidence in this podcast. The point of this is to start to introduce you to these ideas and then point you to where you can go learn from someone who's truly an expert, continue your education. But why do you talk about inflammation in your education around this topic, Dr. Greenblatt?
Sure. I mean, if we take our traditional risk factors for suicide, a trauma being the highest risk factor, we know that trauma in childhood creates a state of chronic inflammation in adulthood. So inflammation cuts across every model of mental health, mental illness, and suicide risk. And the list is long, and we do cover them in the courses, but let's just make a quick list. So trauma. Nobody's going to argue. Trauma, increased suicide risk. Trauma, inflammation. Head injury, traumatic brain injury, inflammation, increased suicide risk. Sleep deprivation, I think one of the most completely missed clinical intervention in our very psychiatrically impaired patients, sleep deprivation, inflammation, increased suicide risk. Our traditional psychiatric community, the American Psychiatric Association, has a suicide assessment and prevention textbook, hundreds of pages. I think that was the third edition, right? They added a chapter on sleep deprivation and suicide. So these are our traditional colleagues with hundreds of references, indisputable. Those that have committed or completed or attempted suicide were sleep deprived. And the mechanism we know is higher inflammatory markers that can be looked at and tested. So almost every path to suicide is an inflammatory process in the brain.
I love that you're mentioning sleep deprivation and inflammation. Guys, just clinically for me, the main reason, I mean, there were a couple top reasons I would send people to the ER. But one of the main reasons, or urgent care or an urgent call to their doctor, was that somebody would come in, they were really, really depressed. They hadn't slept in 3 to 5 days. And this is really actually common in the post-delivery period for new moms and new parents in general, I would say. But a lot of times the conversations we'd be having with those folks are like, you haven't slept more than 3 hours in 3 to 4 days. And if we can't get you sleeping, nothing else we do is going to work. So that is our first priority. Almost irrelevant of how we get you sleeping, right? Like we just need to get you sleeping because when you are asleep, your brain will clean out all the junk and it will start to clean out all the inflammation. But if we can't get you to fall asleep, that can't happen. And so, Dr. Greenblatt, with sleep and inflammation, is that the same conversation you're having with folks? Like if they're wondering, why is it connected? Like this is kind of my normal. I sleep 3 to 4 hours a night. Yeah, I've had a couple sleepless nights recently. Like why does that matter for inflammation and for mood?
Because the sleep is a driver of inflammation. So, as you said, those few days or weeks or months of sleep deprivation is just fueling the inflammatory cytokines. And we actually know how it affects the brain. It inhibits enzymes, so it decreases serotonin synthesis, and the mechanisms are known, but all the mechanisms lead to increased suicide risk.
So, if someone's sitting here thinking, okay, I've had sleep deprivation and I want to think about some long-term natural solutions for helping me to get to sleep a bit faster. What are the top 5 things you'd have them chat with their doctor about as options, whether it's even just looking at their caffeine intake or looking at their stress? What are some of your favorites for sleep deprivation?
Well, let me quote you first by saying, as you just said, if we have a very depressed, suicidal patient, we're going to do anything we can. Please do not worry about a medication to help you regulate sleep, because if you can't, and I use the analogy of kindling a fire, and we can talk about that when we get to social media, but it just kind of that the fire just will get bigger and bigger. So any means is critical. And we also have a lot, as you described, natural means. Everyone's different, but the list is pretty long. For some individuals, it's as simple as just sleep hygiene, understanding basic mechanisms around behavior around sleep and the room and the light and the darkness. Melatonin can be incredibly helpful for some individuals. Magnesium is probably the go-to supplement. Most of our depressed patients are deficient in magnesium. It helps support sleep, so that would probably be the first thing. Other individuals, it's more chronic stress and thinking, and then we might use things like inositol as a supplement or something like ashwagandha as an herb. So the list is pretty long, and a good functional integrative clinician is going to kind of help you around sleep and sleep cycle. If we're in a crisis, don't be afraid of a couple of weeks of a medication to help regulate your sleep cycle.
Thank you. So, so important. And I think for the folks who are listening at home who need to hear this one more time, melatonin is not your ideal tool when you haven't slept in 3 days, right? It's not strong enough. It might not help you enough. You could start that, and in a few weeks, will it beautifully help to balance your sleep? It could be a great part. But if you're having that reaction where you're like, somebody wants to give me a pharmaceutical for sleep, I don't want to get addicted to this, like getting you sleeping for a few weeks while you add that support. And what Dr. Greenblatt just mentioned is a great starting point. A functional psychiatrist or mental health professional is going to also look at your mineral intake, your diet. They're going to look at things like serotonin and GABA support. Like there's so much you could do with sleep, but getting your brain to get a few nights of quality sleep will then make whatever long-term sleep stuff you're trying to do much more successful and help it stick and help you not need that medication anymore. But you got to do things in the right order. Okay, last thing, Dr. Greenblatt, we say inflammation. What do we mean? So, what biomarkers are you looking at for inflammation? And what are some of the root causes you see that might surprise people? I think folks think, well, if I go out on a run and I injure myself, I'm going to see swelling, that's inflammation. What are you looking for in the blood? And then what are you looking for in terms of working up the root cause if you find elevated inflammatory markers?
Yeah, I mean, I think let's just take one other path towards chronic inflammation, and that's infections. So I will share a story. I was at a Lyme conference maybe a year ago. I was invited by a gentleman who lost his son to suicide, who was found to have a Bartonella infection. And he introduced me to two other physicians. So I met three physicians that lost their children to Lyme and Bartonella due to suicide. And it is, again, neglected area in psychiatry and mental health treatment is looking at infections. But how can we think of a more direct path to inflammation than a chronic infection? And I will never forget, I think she was on the front cover of a newspaper article early in COVID. There was a beautiful young woman, an ER physician, who got COVID early in the pandemic and had to take some time off and went home in the Midwest and completed suicide. No psychiatric history, never treated for a mental health challenge. And that was stunning for me, as everything was so discombobulated with COVID early on. But I'll never forget the story or her. And as we started understanding this inflammatory pathway, so infections. So it's a workup, and that takes time and energy and testing. So you mentioned you slipped in vitamin D. Low vitamin D is a pathway to inflammation. We know that. We could do low zinc. We could do infections. We could do obesity. We could do the most common, probably aggravating everything, is just stress. I mean, so all these things, and plus what we talked about, sleep deprivation and trauma and head injury, the list is very, very long. But testing and then treatment based on what we find will be able to kind of tame that fire.
Love it. And some of the typical inflammatory biomarkers that we look for in just medicine in general and functional medicine are things like hs-CRP or CRP, ESR. Are there other things that are purely inflammatory biomarkers that raise your suspicion that something else in the other biomarkers we talked about is going on?
There's not as much that is available, although everyone asks me the same question, and that can we just test for all these cytokines and things like that. But certainly things like high ferritin is also a concern, as well as you mentioned, C-reactive protein. But we don't have great simple tests looking at these inflammatory markers. There's one test, the organic acid, quinolinic acid, which is a kind of neuroinflammatory agent, which should not be elevated. So that is my best path to neuroinflammation that I have, looking at elevations in quinolinic acid.
That's important to know. Okay, good. Thank you. And I think we have some cytokine testing and interleukin testing on Rupa now, which I'm really grateful for. It's difficult to draw and send out because you need dry ice, but it's can be really helpful for people who are trying to actually do a lot of education around which parts of the immune system are activated, especially for families who really want that data. I think the other things you talked about, chronic infection, dysbiosis, allergies, I know you cover this in your course. When you're talking about chronic infections that cause inflammation, let's just go through a short list so that people can keep this in mind when they're working with their own providers or their patients. You mentioned Lyme, you mentioned COVID-19. Are there other ones that come to the forefront of your mind when you're thinking about infections?
I would say the short answer is everything. I mean, we have the pandas kids with strab and other infections that are cutting and intensely suicidal. So I don't know if it's the organism as much as the genetic vulnerability and that inflammatory kind of pathway.
Love that. I think some of the other like chronic infections we tend to think of in functional medicine are things like EBV or mono. So you mentioned a couple of things, other vector-borne illnesses. You can look at the gut. So when you say inflammation and dysbiosis being a source of inflammation, what do you look for testing wise that might clue you in that the gut could be a component?
Sure. I mean, I do organic acids before stool tests. As a psychiatrist, someone presented just with GI issues, but absolutely, as you described, dysbiosis could be the source of inflammation. And we can go on and on with environmental toxins and lots of other issues, but certainly inflammation is likely the pathway to so much of our chronic illness. And how do we address it? Both by testing and lifestyle modifications.
Love it. Okay, last question for you. You mentioned environmental toxins. People might be thinking pesticides. What else? When you say environmental toxins, do you mean things like metals? What are you thinking about when you say that?
Well, I mean, it's a kind of wastebasket term, and I probably don't discuss it at all directly in the course because I have no clear 1 + 1 = 2 like we do with vitamin D or cholesterol. But if we think of some of the environmental toxins that we have tested, like all the phthalates and the plastics, I mean, they all bind zinc and make zinc, less available. And we know there's a relationship between zinc and depression. We know there's a relationship between depression and suicidality. And we could go on and on for elevations of copper and lead and mercury, all affecting these pathways, saying abnormal brain function, micronutrient deficiencies, inflammation. There's just not a great literature to make it a real simple connection, but it's all part of functional psychiatry workup, minimizing kind of the environmental stress on the brain and optimizing the micronutrient environment.
We talked about blood testing. We talked about organic acids testing. Let's talk about the role of hair testing in functional medicine for looking at things like mercury, lithium. You're one of the only docs I hear talking about this consistently, and I think in a really nuanced way that's important when we look at things like hair testing. What do you think the clinical role is of a hair test? What can it help people find out that they may not actually be able to ascertain from blood?
Sure. I mean, 30 years ago, I was doing the same hair test, but I wouldn't get up in front of an audience. I don't think we had podcasts, but I wouldn't talk about it. It was embarrassing because it was just something that just sounded too strange. But at this point, I think it's a fundamental test for every psychiatric patient. And we can't read all the minerals off a hair test and treat it. But there's some that scream. And once it got on TV and these cop shows, they were doing hair testing. Now I can talk about it, right? So heavy metals. So we can look at mercury, lead, cadmium. And we're not going to treat based on a hair test, but it would kind of guide us to maybe do further testing. But the most important ones that I look at, that I do base treatment decisions on, would be magnesium, copper, and we look at lithium. We can pick up lithium on a hair test, and we're seeing more and more undetectable lithium. So it's just a guide. I never use one test, and this is a challenge in our industry to make a treatment decision. And a hair test, I would never do that test and make a lot of recommendations. But having that test, looking at elevations of copper, looking at deficiency of magnesium and lithium, mercury, lead, is critically important for that personalized treatment plan.
I agree with you. I mean, blood test guys are not sensitive enough to pick up low lithium, but a hair test can show if there is no detectable lithium in the strands of hair you send in. That's a very good clue that this person's body doesn't have enough stores of lithium, doesn't have enough lithium, period, and can give you some really good information about the fact that it's safe to start to supplement. Everything else that Dr. Greenblatt mentioned, elevations in mercury, elevations in lead, can be a really good signal that you need to do further workup and treatment, which can be very useful if you have a kiddo or a patient who does not like blood tests. You're trying to minimize the amount of blood tests. It's like day one, they're in the clinic, cut some hair, send it in. It can really give you an excellent start. So Dr. Greenblatt, I want to give you space to have some final words here. And then I also want you to talk about where people can find your course, where they can keep learning from you.
Sure. Thanks, Kate. I think I want to go back to our fire analogy or kindling. So we can just imagine a little small fire and all the things I mentioned, and some I didn't, like addiction, just adds wood to that fire. So we talked about low vitamin D, low cholesterol, inflammation, stress, trauma, everything. And one of the things we didn't talk about, but a lot of people kind of bring up, particularly with adolescent suicide, is social media. So many of these suicides we've been reading about, people were texting or people were online getting support, how to kill themselves. And social media is not the cause of eating disorders or suicidality, but we use the term gasoline on that fire. So if somebody is biologically vulnerable, is in this psychological state of hopelessness and despair, and then this biological state of not being able to inhibit impulses. And then they get that kind of social media connection that certainly can exacerbate this process. So we need to understand the role of social media as we need to understand all the biomarkers that you and I have been discussing. The most important thing, though, is really the simplest, and that is making sure someone knows that their life is of value, that they have value, and there's that human connection. I mean, it is just simple, but in the mental health community, kind of often ignored if we have 6 months waiting list to get your child into treatment. Our programs, this suicide course, I don't know if it's 2 or 3 hours. It is completely free on Psychiatry, Redefined.org. And then my work and my books are on my website, James Greenblatt, MD.
I love it. And this course, guys, is called Biological Models for Suicide Prevention. When you go to psychiatryredefined.org, you just click courses, and then you can browse and find it, especially if you're listening now in real time. It is up on the website. There's a code to make it free for you. I can't thank you enough, Dr. Greenblatt, for the tremendous amount of work you've done over the last 30 years to help patients, but also for the work you're doing to train clinicians in this life-saving approach to mental health conditions and making this course free for everyone. It's huge. I am just so proud to be connected to you and helping you get this message out. Thank you so much for being here today.
Thank you, Kate. It's always a pleasure to talk with you.
Welcome to Root the Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rootthehealth.com.